is the slide visible?
Yes, sir.
Right.
Yes, sir.
Good. Right. Now, we have some other participants who registered from Saudi Arabia and Oman. They are not here yet. Yes, Dr. Aisha Abdullah had joined us. She is from Peshawar Medical College, and she is actually the chief organizer of this activity. Right now, we are going to have this session, and please don't take it as a lecture or something. It's going to be interactive. We are going to talk to each other and share our experiences. We always learn from each other. So if you find that you need to ask something, don't wait till the end of the session. You can stop me anytime and then clarify the point, and then we can move forward. Right? So just take it easy and kind of informal. Right? Again, thank you very much for joining this workshop on standard setting for students' assessment. And our overall outline or plan of this workshop is that we will start with the hands-on activity. Normally, I don't do that. I first have discussion and then hands-on activity, but this time I thought we will try other way around and see how does it work. And I hope you would like it. And from this activity, we would identify the things which we think we want to learn about standard setting, that is identifying our learning needs. And then we will discuss those learning needs. We will learn about that and then apply that information, that knowledge we gain in other standard setting systems like ANCOF, borderline regression, or Needelsky's method of standard setting. So that's the plan, and inshallah we'll try to follow that. Okay, now as a hands-on, I have chosen this method, which is called the Abel's method. And now, what I would request is that when we are doing this hands-on exercise, so please record your learning needs if you feel. Yes, Dr. Mala, we missed your introduction, but maybe later on we'll talk to you. So we have started with this hands-on activity. So the request I was making is that when we are going through this hands-on activity, you please identify or record your learning needs, which you need more explanation about. So the Abel method is a criterion referenced method, standard setting technique, and it is used to determine the minimum passing score or cut score for multiple choice tests. So here, for example, criterion referenced standard setting technique may be one learning need which we might like to learn. And apart from this criterion referenced standard setting technique, are there any other techniques, and what's the difference, and which one may be more applicable in certain situations? Right. So first thing is that Abel method is a criterion referenced standard setting technique to determine the minimum pass score or cut score, and it is only limited to MCQs. So this standard setting method is for multiple choice questions. It was created in 1972, and what it requires is that a panel of subject matter experts, we will be using this term repeatedly, SMEs, subject matter experts, to evaluate each test or each test item based on two dimensions, difficulty and relevance. So means that the subject matter experts, for every MCQ, they would assess that question based on the difficulty level and the relevance to medical profession or relevance to that particular assessment. So SMEs evaluate every question on the test and place it into a classification grid with specific criteria. So here, for example, for difficulty, there are 3 levels: easy, medium, and hard. So obviously we need to define each category, but based on the difficulty, these 3 criteria, and based on the relevance, 4 criteria, whether that information or piece of knowledge which is being tested, is it essential, or it's important, or it's acceptable, or it's questionable, means not sure, right? So these 3 difficulty levels and 4 relevance levels. And when we make a matrix, obviously, it would make 12 categories where each item is placed. So this would be like the table where we have here on the horizontally the relevance, essential, important, acceptable, and questionable. And then in this column down is the 3 categories of easy, moderate, and hard. So we make a table like this, right? And then obviously we will find identify the questions and put it in the relevant cells. I'll show you how we do it. Now, first is this. Look at this question. This question is meant for final professional or exit examination. And we have to identify the relevance of this question and the difficulty level. It is a single best answer question. So Ahmad, a 12-year-old boy who was recently diagnosed to have type 1 diabetes mellitus, presents to the emergency department with abdominal pain and diarrhea for 3 days. Upon arrival, he is drowsy and dehydrated and is noted to have Kussmaul breathing. His blood glucose level is 19 millimole per liter. So this is the scenario. And then the question is, which of the following investigations are most appropriate workup to confirm the likely diagnosis? A, venous blood gas and abdominal X-ray. B, venous blood gas and serum ketone level. C, serum ketone level and abdominal ultrasound. And D, serum electrolytes and venous blood gas. Right now, obviously, this is a case of diabetic ketoacidosis, and the model answer would be the B, where we need to do the venous blood gas and serum ketone levels to make a diagnosis. Right now, would you first, let's say, look at the relevance. What do you think? Is it an essential component assessment? It is an important, it is an acceptable, or it is a questionable? What do you think is the relevance of this question for the assessment of a final year student? Yes, anybody?
Essential, I believe.
Sorry?
Essential.
Oh, okay. Dr. Hira thinks this is essential because this is an important condition, diabetic ketoacidosis. Yeah. Any other ideas? Professor Jamshed?
This is essential because this is an emergency condition and we have to save a life.
All right. Yeah, that's right. That's right. Dr. Zareen? Can you hear me, Dr. Zareen? Dr. Memuna?
सर मैं तो इनके टेस्टों में जो डायग्नोसिस के लिए सीरम कीटोन एंड एब्डोमिनल अल्ट्रासाउंड दीज टूज आर इम्पोर्टेंट.
Right. At the moment, what we are looking at is that is this question an essential knowledge for a graduate, and because it's mentioned that this is an emergency, it can present an emergency. It is a potentially fatal disease, so it is essential piece of knowledge. So we would
Thank you, sir.
we would categorize as essential. Now, let's say this is based on the relevance. What about difficulty level? Yes, Dr. Hira, you think this is difficult, or this is easy, or it's
I
just
think it's moderate. Moderate.
all right? So you think it's at the moderate level, okay? Professor Jamshed?
I think this is easy. Easy because
Yeah, you think this
it's
is
frequently taught in the MBBS curriculum.
right. Now, actually, what we need, but that would be the process that when we are using this able method, for each question, there would be discussion among the subject experts, and they would decide. Now, if we go back to this table, and let's say this is the essential column. So if we think this is essential, Dr. Hira thinks this is moderate, and Professor Jamshed thinks this is easy. So we will put it after discussion. When we come to a conclusion, we will put this number there, right? Okay, let's look at another question. This is for, let's say, a professional examination at the end of preclinical phase. Right? So a 3-month-old infant is brought with bluish discoloration of lips and tongue for 2 weeks. Physical examination reveals a harsh ejection systolic murmur over the pulmonary area. The echocardiography shows a large ventricular septal defect and enlarged aortic root, which is directly positioned over the VSD, stenosis of pulmonary valve, and right ventricular hypertrophy. Obviously, this is a case of tetralogy of Fallot, and rather than saying tetralogy of Fallot, we are describing the components because the question would be based on the components. So the question would be that which of the following echocardiographic findings is the primary cause of cyanosis in this infant, whether it is aortic root directly positioned over VSD, or what we call is overriding of aorta, pulmonary stenosis, right ventricular hypertrophy, and ventricular septal defect. So model answer would be the pulmonary stenosis. Again, let's see from a relevance point of view for um, an examination from, let's say, a preclinical student going to the clinical. Would it be relevant for them?
Yes, very much.
Right? And at what level of relevance would you say that?
Essential.
You would put it in essential, right? Anybody? Dr. Malar, what do you think? You think it is essential knowledge, or it is important or acceptable? You think the students must know the components of tetralogy of Fallot and should know what is the defect which causes cyanosis?
Yeah, it's very essential to know the basics.
Right, okay. Professor Jamshed, do you agree with that?
I think it is important because it is not an emergency.
Sorry?
It is not an emergency.
Right.
It is important.
So you would put it at important, right? So let's say, so again, when we look at the table, so we would, let's say, one group says is essential, and other says it's important, And based on our assessment of difficulty, whether it's easy, moderate, or hard, we would put that question in that table, right? Just one more question, the same scenario, but different level. A 3-month-old infant is brought with bluish discoloration of lips and tongue for 2 weeks. Physical examination reveals a harsh ejection systolic murmur over the pulmonary area. The echocardiography shows a large ventricular septal defect and an enlarged aortic root, which is directly positioned over the VSD, stenosis of pulmonary valve, and right ventricular hypertrophy. Now, this time is not just cyanosis, the mechanism of cyanosis. So asking for pathophysiology, which of the following mechanisms is most likely cause of cyanosis in this infant? Heart failure due to large VSD, reduced blood flow to lungs due to pulmonary stenosis, right to left shunt through VSD, and pulmonary hypertension secondary to VSD. And the answer would be right to left shunt through VSD. Again, we would go through the same cycle and place this question in one of the cells in that grid. Right, so that is the process which when we are using this ABLE method of standard setting, for each MCQ, we would go through that process and will insert into the relevant cells in that table. Right, now this is the example of, okay, there are total 60 questions. 10 of them are essential, 20 are moderate. No, sorry, 10 are easy, 20 are moderate. No, in this, sorry, it should be vertical. So there are 10 questions which are essential as well as easy in that category. Then there are 20 questions which are essential but of moderate difficulty, and other 10 questions again are essential but hard. So total out of 60, 40 questions are essential. Another 15 questions come in important level, and then 3, 10, and 2, and similarly the distribution. So total is 14 easy questions, 33 moderate difficulty, and 13 hard. So if we see basically the majority of questions would come in the moderate. So this is how the table is filled. And we think that all the questions are relevant. None of the question is questionable. So
Sir,
yeah, is this table clear to everybody?
sir, one question.
Yes.
Yes, what is the difference between the important and acceptable?
Let's say we see one question is essential, that student must know. That other is important, that yes, it is important to know, but not really life-threatening kind of situation. Acceptable, yes, it's not important, but okay, this is a relevant question at that level. So in that,
Sir, I think that the essential and are a clinical angle, and acceptable, I think it is the anatomical or pathological basic question related.
Madam, because this would, it is not only for final year, right? So this can be first professional, can be second professional, third professional. So
Okay.
based on the examination level, the criteria might change.
ठीक है, sir.
Right. So that's okay. Now that is the first step, that we have these 60 MCQs and we have categorized those 60 MCQs in this table, which is sometimes we call ABLE grid. Okay, then the next step is that estimate the borderline candidate performance. Means that for each question which we have put in that table, for each of the 12 cells in the grid, the panel estimates the percentage of items a minimally competent or a borderline pass candidate would answer. So then for each question, we have, based on our concept of what is a borderline pass candidate, we would again classify that. And the example could be that the expert might agree that the borderline candidate will correctly answer 70% of the items classified as medium difficulty and essential relevance. Here is let's say, example, right? So these are the same 60 questions. Now, experts agree that under the essential and easy, because this is easy and essential, so let's say 90% of the student would be able to answer. That's the prediction of the subject experts. That's all. And similarly, so values are given. Here is, let's say, 80%, 80%, and this. So this is the percentage of items a minimally competent or borderline candidate would answer correctly. So once we have done this, then the next step would be the estimated percentages are multiplied by the number of test items that fall into each corresponding cell. So number of items times the percentage, and this would be the next step. So here we have, the experts thought that 90% of students would be able to answer that. So there are 10 items, so that's 900. Similarly, all are calculated, 248K, right? So, right. And then what we do is that these values are then summed across all cells and divided by the total number of items to produce the final passing percentage or cut score. Let's see here. Now here we have 900, 240, and 80. So 12 is total is 1,220. Here total is 2,080, 360. So total is 3,660. And once we divide by number of questions, which is 60, so our cutoff score becomes 61. Right? So this would be sort of a minimal score for borderline students to pass the examination. This is the whole process called the Abel's method of standard setting. Any questions before we move forward? I have used this as an example so that we can work it further. Yes.
Sir.
Yes, somebody raised the hand. Yes, please.
This is me, Dr. Bushra.
Right.
Under the essential and moderate,
Right.
you have multiplied 70 times 20. Where does that come from?
Oh,
I thought you taken the percentages.
Okay, 70% and 20 is number of items. So what the experts thought that in this category,
Okay, got it.
Yeah, 70% of the borderline candidates will be able to answer that. So here at in black we have number of questions, and then in first red with the asterisks are the percentage of students who are expected to answer that question correctly, and then we multiply them and then we get this number, and then the total number divided by total number of questions, and that gives us a cutoff score.
Sir, I have a question.
Yes.
Sir, the subject matter experts would decide how many students, the percentage of students would be eligible to answer the questions?
Right. Not eligible. They will be able to answer.
Able, yes.
Yeah. They will be able to answer.
And it will be decided after mutual agreement.
That's right. We will go through the whole process. Again, as you rightly said, That is one of the learning need, that who will be the subject expert, how we would identify the subject expert.
Sir, 90 would be student and multiplied by 10.
Yes, 90, you can say
Subject.
student as well. That out of, let's say, 100, 90 students will be able to answer this question correctly. You can put it that way as well.
Sir, is there any limited number of subject matter
And this
experts
10,
that we require?
getting 10
Right.
is that they are
Yes,
Sorry.
absolutely right, Dr. Ira. That's actually what I wanted, that from this exercise, so you come up with questions which we need to answer. Yes, we will go to and discuss that, how many subject experts are needed. But that's good. You are identifying the learning needs. Yes, Madam Memuna. Yes, please.
सर प्लीज सर ये 10 20 और 10 ये क्या एक्सप्लेन कर रहे हैं?
देखिए मैडम, ये जो
नंबर ऑफ मार्क्स और नंबर ऑफ स्टूडेंट्स,
ये जो this is number of questions. You see this black, the same black is here, 10. This black, same black is here. So maybe I should put it as a black because it is the same number. So there are 10 questions, multiple choice questions, which are in the category of essential and easy. And the subject experts decide that 90% of the students will be able to answer that question correctly. So 90 times 10, that gives us 900. So this is the same 10 at it is there. Maybe I should make it black here. So that would make it easy. Right? It is the same number. So 10 is the number of questions, and 90% students will be able to answer that. Right? Any other comment? Okay, now don't worry, we will be discussing this in a bit detail, because at this stage our aim is to identify what we need to learn more. So if I summarize the learning needs, the first thing is we use the term criterion referenced standard setting. What does that mean? What are other methods of standard setting? That's number one learning need. Number two, who are subject matter experts? What is the criteria for identifying these SMEs? How to define the level of difficulty of a question? How to define the relevance of a question? How to identify minimally competent or borderline pass candidates? So these are all questions which are generated through this exercise, and we will in our next discussion would go into the detail. We learn about it, and then we would apply this information to other methods of standard setting. Right? So this is the part we are going to go through based on our learning needs, the standard setting for students' assessment. So, and those learning needs are now is our learning outcomes of this session. After attending this workshop, the participants will be able to explain the concept of standard setting in medical education, explain the rationale for use of standard setting for students' assessment, discuss different methods of standard setting, choose relevant standard setting methods for their selected assessment tools, and implement standard setting processes in their institution. That is, hopefully, you will be able to train your other colleagues in the staff development so that this method may be applied in your respective institutions. Right. Now, the first question, grading systems in different countries and how to arrive at a mark. Now here, let's say this is the grading system in Australia. HD, D, C, P, and N, and HD stands for high distinction, D for distinction, C for credit, P for pass, and N for fail. And this is their criteria, that to have high distinction, the marks should be from 83 to 100%. Similarly, for distinction, 73 to this and then. And this high distinction corresponds to the GPA of 7. And this is equivalent to US A plus, and in UK, this would be the first class. So this is, let's say, a grading system used in some of these countries. Now, issue would be here that the pass and fail. So how to actually work around this, that how to decide who is pass and who is fail, and mainly the standard setting system work here, although it can work in other levels as well. There are some other questions which we may ask ourselves. Who decided that the pass mark should be 50%? When was it decided? Why it was decided? What was the criteria used? How to decide which student has failed? Is borderline, or is minimally competent, or has passed?
You're there, guilty or
Sorry? Yes, Dr. Alia, you want to say something? Right. And the third question is how to arrive at a pass mark. In multiple choice question examination, a student can score 20 if there are 5 options. So R25 if 4 option marks by chance. So should it be added to 50%? Should the pass marks be 70 or 75? These are basic, very fundamental questions in our assessment, that how do we decide and why it's the 50% pass marks. So what a little bit this slide on the history of this approach. The ancient Greeks used assessments as formative and not evaluative learning tools. So begin with these assessments were formative, means that they would give feedback to the students so that they can improve on that. And it was only in 1646 that Harvard required exit exam to attain a degree. And it's more than 100 years later, the Yale University, they created a grade scale of 4 descriptive objectives, which is optimi, second optimi, inferiors, purgors, are best, the second best, the low, and the lowest. And over the next century, Yale refined its grading system to numerical points measured from 0 to 4, with the 2 serving as a passing mark. So that's how where the 50% came. So there were 5 grades from 0 to 4, and in the middle they decided to put it as a pass mark. Right. Now, what is the rationale and what is the concept of standard setting? We need a meaningful and essential performance criteria designed to provide evidence that candidates have successfully completed the task. I think this is obvious. We must have an essentially designed criteria to decide that somebody has passed or failed the examination. The test developers need an educational tool by which they determine the cutoff point on the scoring scale that separates the non-competent from the competent. Again, that's very important in our assessment, that we should be able to separate the non-competent from competent, and that's how we need some kind of a scale which is based on a specific criteria. The traditional approaches in defining such a cutoff point, for example, responding correctly to 70% of the items, do not provide robust and valid evidence for pass-fail decisions. Moreover, a fixed cutoff point may not be applicable universally. So we may not be able to use the same cutoff point across all different kind of examinations or of assessments. What is standard setting? So standard setting is a process to distinguish between a competent and an incompetent student. We just discussed that that it is very important for us that during our process of assessment, we should be able to distinguish between a competent and an incompetent student. And this is what exactly the standard setting does. And it does by determining the score associated with the minimum level of skill or knowledge required to reach a certain level of achievement or cutoff mark. So when we are deciding pass or fail, we have to have a minimal acceptable level of knowledge and skill. If the student has achieved that, then we would say, okay, this student has passed. Otherwise, they may need further training. Based on the criteria, the candidates may be placed into a greater number of achievement levels. Then we have this fail students, borderline pass students, clear pass students, good pass students, are excellent, and distinction. We do use these terms, and each term has a numerical value behind it. Standard setting is crucial part of quality assurance. Yeah, that's another important aspect of standard setting, that it's not only just pass or fail, but it also is to maintain our quality. If the cutoff score is incorrect, the exam results will be affected, obviously, which could have huge implications. Standard setting helps to determine minimum level of acceptable competency to declare a student successful in a particular examination. The minimal acceptable level may be different in different examinations or components of examination. Yeah, so we will discuss this in detail, because as we just learned in the ABLE method of standard setting, that each question has a different level. So we cannot apply the same standard to every question. So minimal acceptable level may be different in different examinations or component of examinations. For example, if we are having OSCEs, so at the minimal acceptable level in one OSCE may be very different than the minimal acceptable level in another OSCE, depending on the nature and importance of area being assessed. For example, look at the minimal acceptable level of cardiopulmonary resuscitation as compared to abdominal examination. So our minimal acceptable level in cardiopulmonary resuscitation would be very, very high as compared to abdominal examination. So that is what it means, that it depends on the nature and importance of area being assessed. Right. So that is the concept and the rationale of using standard setting. Any questions so far? Any comments? Right. So seems everything okay. So we move on to next, that the categories of standard setting, and a number of standard setting approaches are currently available for both written and performance tests, some more appropriate than others for different types of assessment. I think this is one important thing which we should remember, that one standard setting method may not be appropriate for all kind of examinations. Some standard setting method may be more appropriate for written examination, whereas others may be more appropriate for clinical examination, for example. So one standard setting method may not be appropriate for all types of assessments. And in this workshop, we have done the ABLE method. The other methods we would be looking at is modified Ankoff, borderline regression, and Nidelsky's method. So we will use these methods as an examples to explain the standard setting frameworks being used in different medical schools. Yes, there is a hand raised by Dr. Shazia Fakir. Yes.
अस्सलाम वालेकुम सर,
वालेकुम
माय
सलाम।
नेम इज डॉक्टर फातिया फाखिर और मैं मेडिकल एजुकेशन को हेड कर रही हूँ बहरिया यूनिवर्सिटी में। मुझे
Right.
ये आई एम रियली इट्स वेरी नाइस एंड एक्सीलेंट एक्सप्लेनेशन ऑफ स्टैंडर्ड सेटिंग methods and my only concern is that isn't this a very strenuous procedure, and would all the faculty members agree that each and every question needs to be given a set of percentage, and every exam is different, and every MCQ and every OSCE? So is this happening anywhere in the world? Is it actually, how long does it take? I'm really concerned how
Yeah,
to make
madam,
them agree
yes,
to do this.
I do understand your concern. It
How do
is
I convince my faculty that this has to be done? Just
right.
that's my concern.
I think one
Thank
point which very important for us is that we have to be answerable for our decisions.
Right.
If we are say somebody fail, we have to be answerable for making that decision. Similarly, if we say somebody pass, we have to be answerable for that decision, right? So this means that our decision should be both legally and morally defensible, right? So this is
Right.
really an important part of our responsibility, because our decision is going to have lot of implications on individuals and community. That's number one. Number two, I fully agree that it seems quite a tedious process, elaborate process, but it is elaborate and tedious just to begin with. Once you have started and people have understood it, then it doesn't take long. Because when you have, let's say, 60 questions and the SMEs are sitting there, they can quickly decide whether it is essential, whether it's important, or whether easy or difficult. Once we have understood it, and then it wouldn't take long, but obviously we need to call a meeting to do that. Thirdly, to say that it is being implemented, yes, it is. For example, in our medical school, we are implementing it in different areas. Recently, I was in, not recently, maybe a couple of years ago, I was in Iraq, and there were medical schools, they were implementing it. So different medical schools may be implementing, let's say, some schools may be implementing only on their OSCE. Others may be implementing both on the written and clinical. So, and we will see later on that how can we proceed and how can we work on that. Having said that, I'm not saying that this is a foolproof method. It has its own limitations. It has its own issues. And but what my personal feeling is that it is a lot better than just doing it the way we are doing. So if we feel that this is our responsibility to be fair, to be answerable, I think we might have to go through this exercise, but only the first time would be difficult. Later on, it wouldn't be.
Right, sir. Thank you so much. Thank
I
you,
hope
sir.
that answered your question. Yeah. Right. Any other questions or comment?
Sir, with regard to the same question that was asked by our worthy participant,
Right.
I would just like to add that when it comes to assessment, it is always tedious. Even when we have to do the item analysis, post hoc analysis for assessments, the faculty has to be convinced that this is needed and what is the importance and utility of it. And when we keep on doing it and it becomes a habit, then it becomes easier. The problem is with the undergraduate level, a College of Physician is doing standard setting for their exams, but for the undergraduate level, we are stuck up with that 50% that the regulatory bodies are giving us. And the problem with that is that it is not at all defensible to let somebody graduate with less than 50% of the essential knowledge, skills, and behavior that is required of them for a practicing doctor. So that's a dilemma that we are facing at the moment for summative assessments. But for the formative assessment, we can certainly do that. And if we prepare the students through formative assessments with standard setting at 75% or 80, or maybe at, like for CPR module, at 90%, then the students would, inshallah, hopefully, would be able to meet more than that 50% cutoff score that is being given to us.
That's well said, Dr. Aisha. And one thing which you have not mentioned is the vetting. A very tedious part of vetting the questions where people may actually get angry with each other as well.
Exactly.
I agree. I totally agree. All these things they make faculty very angry. But I guess we have to convince them that it's how important it is legally and morally. So,
Yeah,
thank you so much.
you see the relevance and the importance, and making
Sir.
such a big decision. I mean, for one individual, it may be, let's say, question of the whole career. Right.
Right.
So,
right.
yeah,
Exactly. Yes, sir.
it's really worth working on. Really worth working on. Okay, let's
Yes.
move on. Right. Now, the standard setting methods, there are two main categories of methods used to calculate the cutoff score. One is norm referenced, other is the criterion reference. And if you remember, we use this term criterion reference for able method of standard setting. And then now we would explain that. What is norm referenced and what is criterion referenced? The norm reference, these are methods that are used to calculate cutoff marks where the number of passing candidate is relative to the to the rest of the candidates. So here there is no criteria, but here is the student's performance in relation to their other peers. For example, one institution may decide that, okay, 25% of the candidates who performed worst, or maybe 25% of the lowest, from the lowest scorer, they would fail the exam. So this would be a norm reference where there is no criteria. Students just appear in the exam, and we decide that, okay, first 75% pass and last 25% fail. This is example of norm reference. Norm reference methods are useful in situations where there are limited number of places available, such as entrance exam. Like in your medical school, for example, there are 100 seats and there are 500 candidates who have applied, and then you have an entrance test. Obviously, you can choose only 100, so you will choose the top 100 and others would not be eligible for admission. So this is what is called the norm reference. They are not widely used for high-stake examination, as this process does not actually define how well a candidate performed in an examination. Just how that candidate performed in relation or comparison to other candidates. So it's not really a useful method or not acceptable method for our high-stake examinations. The relative standard, or same the norm reference, can be set at the mean performance of the candidates. So we can decide, one way could be that we take the mean of the marks and decide, okay, above that is pass and below that fail the students, or by defining the units of standard deviation from the mean. We can use a percentile chart, or we can use a median point to come up to a norm reference standard. And these standards may vary from year to year, obviously, due to the shift in the ability of the group, and may result in a fixed annual percentage of failing students. So this means that in this system, there would be always failures. Some students would fail the assessment. The weakness of this approach is standards are not content related. A number of candidates may fail each year. Examinees' ability may influence the standard, obviously, if the student's performance would influence that. Standard is not known in advance, and diagnostic feedback. So we wouldn't know the reason why are in which area the students are not performing well than others. So this is what is the norm referenced method. But as we see, it is more suitable for example, entrance exam and those kind of things. The second method, which is the criterion reference or absolute method, these are standard setting methods where the cutoff mark is based on a well-defined standard as opposed to relation to each other. So here is that we have a criteria which is decided, and the students are judged against that criteria, not against each other. This means that any number of candidates could pass or fail the exam, depending on whether or not they meet the minimum defined standard for the assessment. And these methods like NCOF and borderline regression are methods of this, and the criterion reference, and Abel was also the criterion reference. Assessments in medical education use criterion reference methods to determine mastery of the candidate, and norm referenced are relative methods to rank the examiner. So we may use the criterion reference to make a result, and then to rank the student, we might use the norm reference that let's say what we say is the distinction students and good pass students based on that. So there we can use the norm reference to some extent. An absolute standard stays the same over multiple examinations relative to content specification of the test, and the failure rate may vary due to changes in the group's ability from one examination to the other. So in criterion reference, it's possible that 100% students may pass or 100 students may fail, depending upon whether they meet the criteria. Right, so this is so there is a norm reference, there is a criterion reference, but in our high stake examinations, we are using the criterion reference, but we can use norm reference in other areas, not in high stake examinations. Okay, next is this methods of standard setting, and they can be divided into two: test-centered and examinee-centered. Test-centered means that, for example, the Ankoff method is a test-centered, means that we are looking at the examination questions, whereas examinee-centered is that we are looking at the performance of the students. And we will be going into detail of Ankoff method in test-centered and borderline regression in the examinee. So these would be the examples of these methods. So the test versus examinee centered methods is just try to understand that the test centered methods, the standard setters estimate the probability that a minimally competent student will answer the items correctly. The items are difficult or easy for a minimally competent candidate. The most popular test center methods are Ankoff, Abel, and Nadilskis, and these are before the examination. That's important to understand, that these test center methods, they are before the examination is conducted. So looking at the questions, we would have a criteria before the examination is conducted. In examinee-centered method, on the other hand, the pass mark is based on students' actual performance on a specific assessment, and that is after the exam. Like in these methods, students' performance are scrutinized rather than assessment questions, and the most popular centered methods are the borderline regression model, which we would be going into detail in a short while.
सर एक्सक्यूज मी
Yeah.
सर ये सी से क्या बनता है? मिनिमली तो एक एम के लिए, दूसरे एम से क्या बनता है?
जो पहले दो एम है वो मिनिमली से हैं, मिनिमली कॉम्पिटेंट, एमएमसी, मिनिमली कॉम्पिटेंट.
ठीक है,
Right.
थैंक यू.
Welcome. Okay, now sometimes when we are working on these standard setting methods, we might confuse that with that they are a marking guide or marking scheme. They are not marking guide or marking scheme. The standard setting does not look at how you are marking your students, right? So that is totally different. Standard setting is applied only once you have assessed the students you have already marked, or before you mark that. Okay, so that was the sort of concept method and the rational method and theoretical basis of standard setting. If there is any question, we can discuss before we go straight into Ankoff method of assessment. Any question, any comment? Right. Okay, now let's look at the Ankoff method. Ankoff is a well-established method of standard setting. It is most commonly used in high-stakes examinations such as OSCE and MCQs, and is most reliable when supported by another standard setting method. In our institution, we are using this for our OSCE. The Ankoff method requires expert judges to discuss the issues involved in determining a pass mark. Same like we had this subject expert methods mentioned in the Abel method. So the expert judges to discuss the issues involved in determining a pass mark and to evaluate the examination by using a well-defined and rational procedure. The NCOF method is based on the concept of borderline pass or acceptable minimally competent candidate. The subject matter experts are asked to evaluate each item, as we did in above, and estimate the proportion of minimally competent examinees that would correctly answer the item. Here, we would not be using like with the classification of based on the relevance and the difficulty. So that is very specific to able method only. The ratings are averaged across raters for each item and then summed to obtain a panel recommended raw cutoff score. And this cutoff score then represents the score which the panel estimates a minimally competent candidate would get. I think the example would make it clear. Right, okay, these are 10 questions here. And let's say in this example, there are 10 judges. So this is in question 1. And the first judge says that the 60% of the candidates would be able to answer that question correct. So similarly, second judge, third judge, and then we take an average of these 10. Same process goes on for each. For each questions, and then we have this mean of these 10 questions, and then we get a mean of these 10. So in this, for example, in this example, the cutoff percentage would be 57. So again, there are judges, and each judge gives, here we will say the subject matter experts. Each expert give his or her opinion based on their experience of what they think is a minimally competent student would perform. And then we get the average of that, and then we get average of averages to get the cutoff percentage. This is an example of NCOF method. The modified NCOF method is preferred over original method. And here what we is that in a modification adds to the process by provision of data about difficulty of the items based on the actual performance data. So let's say in original, the NCOF method, the SMEs don't have any previous data with them, but in modified NCOF method, the SMEs may be provided data of, let's say, some previous exam or trial exam, so that they can get an idea that what level of a minimally competent student would have. But just keep in mind that it is so important. It is so important to have a uniform understanding of a minimally competent candidate, which we will be discussing in detail, because I think in the whole process of standard setting, the most important component is the identification of a minimally competent candidate. The NCOF method depends on the SME's degree of familiarity with the minimally competent test taker, as I was just saying there, who is neither qualified nor unqualified to pass the test. That was the definition given in 1995. And this task is highly dependent on the capacity of SMEs, right? That's exactly what we were discussing, that it is so important that SMEs have a clear view or clear picture or clear understanding of what a minimally competent candidate has. Right. Now, some issues about Ankoff method. This is subject to decision bias, element of subjectivity. So it depends what is the approach of SMEs and what criteria they have in their mind. The SMEs has to understand how the minimally competent candidate will respond to the required performance task. And the SMEs must also be familiar with the expected level of examinee performance as defined by the purpose of test. I will explain this. What does this mean? Seems a complicated sentence. The SMEs must also be familiar with the expected level of examinee performance. So they should know what is expected or what is the level of minimally competent candidate acceptable. And also by the purpose of the test, I'll give you that example, and be able to understand the degree of difficulty of the task. So a modified Ankoff method is a test-centered approach, is a criterion referenced, relies on SMEs' judgments, requires understanding of minimally competent candidates' characteristics. Actual performance data are provided to SMEs. This is a modified Ankoff, that the previous results are shown to them. And that helps them to have some picture of what is expected of a minimally competent candidate. If I explain it in the steps, how it is performed. So first is that we need to select and then train subject matter experts. That's very important, because training would bring the common thinking are the same page. And I'm not talking about training of days and years. It just may take 1 or 2 hours to come to that. Then we define a minimally competent or borderline pass candidate. Then rate a few example items and discuss. So when let's say we have selected the subject matter experts, and then we are training them. So what we do in training, that we give them few questions and ask them to give their opinion about those items in terms of how they think the minimally competent candidate would perform, rate all actual items, and discuss item with poor agreement. So in the items where the subject matters specialists are not agreeing, they have different ratings, we would ask them to sit down and sort out and come to a consensus, do a second round. So once they have discussed, and then in the second round, they would come to a consensus on the poor agreement items, calculate the cutoff score, and rate each item on the percentage of minimally competent candidate that would get correct, and implement the Buke compromise. Now, so this, if I go through again, the select and train subject matter, important. Define a minimally competent candidate. So everybody should agree what a borderline pass candidate means. Rate a few examples. So give them some questions, maybe previous questions, and they rate, and then they see the difference among them on those items, and they discuss among themselves. Then we give them the actual items and ask them to rate those items. And if there is some disagreement, then we ask them to discuss again and come to a consensus on those items where there is a poor agreement. And then they would sort it out in the second round. Then calculate the cutoff score, like I showed you in the previous table, and then rate each item on the percentage of minimally competent candidate that would get correct and finally implement the Buke Compromise. What is Buke Compromise? Is a passing score that is viewed as appropriate with respect to both absolute and relative standards. So there may be one item where there is a difference of opinion among SMEs, so they are asked to compromise. And interestingly, the term is used lose-lose framework. It's not win-win framework. It's a lose-lose framework that both the groups have to give up some of their opinion and come to a consensus. So a compromise strategy is a negotiation and conflict resolution approach where both parties make concessions to reach a mutually acceptable agreement. So this is, there may be one or two or maybe few items where the SMEs are not agreeing with each other. So in those cases, there might be some discussion and finally mutually acceptable agreement is reached. That is what is called the Buke Compromise. Again, the same example of some compromise, which would be here in OSCE, for example, then the designing the perfect exam requires compromise between three factors. Let's say first is realism. Replicating a stressful real-world hospital shift. Obviously, in OSCE, which is in environment outside the hospital, so we cannot replicate the same stressful situation. So there is some compromise on realism. Then standardization, giving every student the exact same fair test. Yes, we do try our best, but that especially when there are we are using patients, so there may be a little bit difference here and there. So that's another compromise. And third is the validity, that accurately measuring a student's competency. So let's say normally we would say that there should be a complete history taking, which might take 30 minutes, but of course we cannot take 30-minute OSCE, so we have to compromise there. So medical schools must balance the time and resource available with the number of stations required. For instance, testing a student's entire history-taking ability might take 30 minutes, but a compromise involves breaking the exam into shorter 5 to 10-minute stations to broadly cover more topics, sacrificing depth for breadth of knowledge. So these are two compromises which we normally make during our examinations while using this standard setting method. One is Buke compromise, and the other is compromise strategy in exam design based on our resources and the facilities available to us, and keeping in the spirit of OSCE of standardization. Right. So now we are moving to the next step, which is implementing the standard setting methods in institution. What is the process of standard setting based on the steps and the staff training? So now we have been talking a lot about the subject matter experts, and obviously this is very important. I think the first or the most important is how to define a minimally competent candidate. And second most important would be the selection of subject matter experts, because the opinion of subject matter experts can change the whole thing drastically. So how do we select the SMEs? The importance of SME selection for the creation of a defensible standard setting process cannot be overemphasized. And the Hambleton in 1995 describes a defensible process as one which is based on, so the criteria he used is selection of appropriate SMEs. That's one important component. Excellent SMEs training is another component, and a well-planned and systematic standard setting process is a third point, which provides ample opportunities for discussion and deliberation among SMEs. So this is the for proper defensible standard setting process. These steps are important. Selection of SMEs, training of SMEs, well-planned, systematic standard setting process, and the opportunity to discuss and deliberation among SMEs. The reliability of the performance standard will be reflected by the degree of agreement among SMEs. Right, we have discussed that in detail, that agreement is very important. A reasonable performance standard will coincide with expectations about the specified professional performance. So this is one way of looking at it, that once the SMEs have discussed among themselves and they have come to a conclusion, and that should appear as a sensible decision, that should be agreeable and acceptable and appear sensible. So that's another way of looking at it, that the decision made by SMEs is not really very, very odd. That seems totally out of place. Now, what is the criteria of selecting the subject matter experts? One, they should be expert in, of course, in the related field, based on the subject and the area of assessment. Familiar with the examination methods, right? Obviously, they must know what is the examination method, and they should be good problem solvers, familiar with the level of candidates, and interested in education, must be teachers. So SMEs should be the teachers from the related field, and they should be not only teachers of the related field, they should be familiar with the examination method. They should have the ability of problem solving, and they should have some idea the level of the candidates. Here is an example to elaborate that point, that subject matter experts for a 4th year OSCE for progression to 5th year in this example. So the subject matter expert must be familiar with the performance of 4th year students. He or she must have knowledge about the next phase of training in the graduates are expected. In other words, that what is expected from students who are entering year 5. And then they should be familiar with the OSCE, because this is the examination is OSCE, and experience as a clinical teacher. And in addition, adequate mix of gender, age, seniority, academics versus community experiences, and other relevant attributes will further establish the defensibility of the standard setting process, right? So I think this example would help to understand that we are choosing as subject matter experts for an OSCE in 4th year. So obviously these points need to be there, right? Any comment on this? Or is it agreeable for everybody that should be the criteria?
Sir, I agree with the criteria. I just have one question.
Right.
You have listed many qualifications for the subject matter expert, but who would be identifying? The medical education department, or the departments themselves would be electing one subject matter expert? That is a gray area for me right now, that who would be nominating these subject matter
Yeah,
experts?
I think it would be the department,
Okay, okay.
because the medical education unit would come into place later when it comes to the training.
Right,
Yeah,
right.
so different departments would select their SMEs, and then they would gather, and then the medical education department would conduct the training session and the process as a whole.
Okay, thank you, sir.
Right? Okay, now how many, that was the question asked previously also, that how many SMEs are required. Although the exact number of SMEs required is still controversial, and studies have yielded results as low as 5 and as high as 20. Most suggestions revolve around a group of 10 judges as suitable for this purpose. And I fully realize that it may not be possible to get 10 people, right? So what is that, as we can say, as many as possible, but if let's say we have more than 5, that would be good. Right. So once we have selected the SMEs, they have been nominated from different departments based on the criteria sent to them by the medical education department, then what next step would be how to train these subject matter experts. So first step would be the facilitator, the one who is training them, presents to SMEs a general overview of the OSCE test. I'm using OSCE as an example. The duration of each station, test components, scoring methods, and any other information from which the panelists may benefit. Remember, as I mentioned earlier, that the standard setting method is not a scoring method. So scoring method is already in place, and the facilitator would present that to these SMEs. So central to the orientation session is a statement regarding the purpose of the test. Now, this is another important component of these two are important concept to understand. For an OSCE, the purpose may be read as follows. The graduates of this medical school should demonstrate at least minimal acceptable competence in history taking, physical examination, and doctor-patient communication for the purpose of entering a house officer training program in Malaysia. Right? So this is, let's say, the purpose of that examination. Now, if we are, let's say, talking about the exit examination. So this statement says that the graduates of, let's say, my medical school should demonstrate at least, if they do not demonstrate this minimal acceptable competence, they should not be graduate. And the minimal acceptable competence in the areas of history taking, physical examination, and doctor-patient communication. And the purpose of this is for entering as a house officer, right? So that is the requirement to join the Ministry of Health as a house officer, not as a medical officer, because I'll show you how does it matter. So this is the purpose of that examination, which has been stated to the subject matter experts. The purpose statement may help SMEs to choose either conjunctive or compensatory approach. This too, again, it might seem that I'm trying to make it difficult, but it's not. You will understand it very, very quickly, because the why we have that purpose statement, and that influences the approach of the SMEs, and they may have a conjunctive approach or a compensatory approach. Compensatory approach is that, for example, an examinee with a low score in skill A can pass if they score exceptionally high in skill B. Means that one OSCE result can compensate for another OSCE. This is the compensatory approach. And this means that it may be that at the end of the day, we add up all the OSCE station scores and take the percent, the average, and if student has passed, we pass. In the sense that because each station has its own minimally competent level. So, but if we keep it to this, that in compensatory approach, an examinee with a high score in skill A can pass if the score exceptionally, so in one is very low, in other is very high, but they're combined, they pass. This is the compensatory approach, and it would come into play in just a minute. I'll explain. And the conjunctive is that the candidate must pass each station independently. Right? So at the moment we say that in compensatory approach, the result from one OSCE can compensate for OSCE in the other station, whereas in conjunctive, the student must pass all stations. Now, how it works is that when we say that the candidate is going to join the house officer and there would be a training available as a house officer as well. So the SMEs may think that although student is weak at this level, but they have an opportunity to rectify that weakness as a house officer because the training would be provided. That is the concept behind compensatory. So minimally competent concept and the continuing supervised training as a house officer, for example, direct panelists to consider compensatory versus conjunctive standards. The medical and educational assessment in exams like an OSCE, student often must pass an aggregate score and pass a minimum number of individual stations because some stations are so critical. For example, this is a station on cardiopulmonary resuscitation. So that is must that the student must pass that station. And obviously the minimum competence level or cutoff score would be very high in that because of the nature of that station. So that is the conjunctive and the compensatory approach. In other words, when we say that student after this is going to be a house officer, and for example, in Malaysia, the house job is for 2 years. So the subject matter experts may think that the student would have an opportunity to rectify if there is a little weakness at this stage. On the other hand, if we talk about the conjunctive, let's say house officer going to work as a medical officer, then obviously then there would not be compensatory approach, there would be conjunctive approach, because after training in house job, the graduate is going to be working as medical officer and working independently. So they must have the required competence before they join as a medical officer. So I think this explanation would clarify the concept of what is compensatory approach and what is conjunctive approach. And the reason why we are discussing this, because when we state our purpose of that examination before the subject matter experts, it influences their decision. So that was the reason that we wanted to explain this. The step 2 in training is that SMEs go through the following documents: instruction for the candidates, instructions for the patients if we are using the standardized patient, and the marking scheme. And SMEs identify the minimum pointers that a candidate must demonstrate for passing the station. This is again a very important step, and step which make sense. SMEs identify the minimum pointers that the candidate must. I'll explain in a minute in the example. Now look at this. This is a marking scheme of an OSCE, and the station is counseling about use of inhalers in asthmatic patients, right? And this is the marking scheme. There is an introduction that greet patient and introduce self. Then there is a counseling technique, and there is a necessary information to the patient, the communication skills, etc. Right? So this is the marking scheme. Now, the SMEs may be required to identify the essential components in this scheme, which if a candidate does not meet that essential requirement, they would not pass the station, right? So this would be identification of a minimally competent candidate. Now look at this. So this is, okay, now SMEs have identified these points which are essential for a candidate to pass. So means that, for example, greeting the patient, informing the patient about the purpose, identification and avoidance of triggers, compliance to the treatment technique and the initial treatment, and language clear. So this means, and this would make 9 points. So total marks for this, if we follow this marking scheme, is 15, but to pass this, the OSCE station, candidate must conform to these 9 points or 9 marks. So this is how one method of identifying the requirement of a minimally competent or borderline pass candidate, that we look at the marking scheme and we identify the most relevant, most important points, and they highlight those, and that the candidate must meet this criteria before they are allowed to pass, right? So this is one way of doing it, and I think it's quite useful. The next step in training is the full description of the station, how it was examined previously, checklist, which I just showed you, the history, physical examination, and counseling. They may be shown the videos, the one up from the previous examination, the low performer and high performer, and they may be asked to mark those candidates on the video, and then the actual marks are shared with them. So this is another step of training the SMEs so that they have the similar understanding, that using a video of a previous examination of a low performer student and a high performer student, and then comparing their marks with the actual marks which these candidates received in the previous examination. So what I'm trying to show you here is the different steps and different methods of training the SMEs, as it is so important that they should have a similar thinking about the level of a minimally competent candidate. The next step is that set agreed criteria for an acceptable minimally competent or borderline pass candidates, and then apply this. Let's say, imagine there are 100 such candidates, and then that for each item, whether it is a multiple choice question or OSCE, what percentage of minimally competent candidates will pass in that question. So once we have trained them and they have a picture or an idea of what is expected of a minimally competent candidate, then they can give their number. Let's say, and that's the way the question is asked, that imagine there are 100 such candidates, and then question by question determine how many of these 100 candidates will answer the question correctly. That's what we did, let's say, in Abel's method as well, and also in the previous example of this Ankoff method. And then get an average for each item, and then average of all the averages, the table I showed you previously as well. So that's after training the SMEs, then they are asked that imagine there are 100 candidates, and out of those 100 candidates, how many of them will be able to answer this question correctly. The means we are talking about minimally competent candidates. We are not talking about all the candidates, or we are not talking about the top tier candidates. We are talking about that if there are 100 minimally acceptable level candidates, how many of them would be able to answer that? And that's how all 10 judges would give their figures, and we would get an average. And for each 10 items, we have these averages, and then we get an average of these averages, and that becomes the cutoff percentage point. And this is done in the Ankoff method. Things to consider here is what concept is being tested. Is it difficult concept to understand or grasp? Is it a general concept that everyone will know or be familiar with? Is the question straightforward? Are there common misconceptions or mistakes that might be made by someone at the entry level? If you do not know the correct answer, neither will the minimally qualified candidate will. Yeah, that's one way of looking at it, that if I am an SME and I also don't know the answer to that question, then I shouldn't expect from a minimally qualified candidate to answer that question, right? And then here, yeah, again, very important statement to my mind. What the MMC, a minimally competent candidate, will know, not should know. I think when SMEs are working on each item one by one, it should be whether the candidate will be able to answer or will not be able to answer. It should not sound like that they should be able to answer. No, it's not question of should. It's whether they will be able to answer or they will not be able to answer. Yes, of course, everybody should be able to answer that question, but whether that minimally competent candidate will be able to answer or not, the question should be in that form, not in the should form. Ratings for each question should range from 25 to 95. 25 is because if there is 4 options, so there's a 25% chance of getting the right answer. So that's how they figure. But if it is a 5-item question, then it would be 21 out of 5. And to 95, that it is unusual that all, if we say 100, that means that all the minimally competent students will be able to answer that. So the lowest level usually is kept based on the type of question, 20 or 25, and highest as 95. And that has its impact that lower rating indicate more difficult items, where high rating indicate easier items. Obviously, if higher number of students are able to answer that, so it's an easy item. Giving high or low rating to items will raise or lower the final passing score, which is quite obvious. Right. So any questions or comments about the SMEs? I think there were concerns shown by some of you about the SMEs, and that is absolutely right, that we have to be very, very careful about the selection of SMEs and the training of SMEs, because they are going to make the important decision, and we should provide every opportunity for them to get the right picture. Any questions or comments? Again, as I said earlier, it might seem elaborate, but this training may just take maybe about 1 hour or so. So it's not that this training, and once you have trained them, you may not need to repeat that training again and again. That's why usually the first time it takes a longer time and appears tedious, but subsequently it becomes routine. Right, if no question, then move on to the next component, and which I said is the most important component of standard setting approaches, is defining a minimally competent candidate, because that can change the whole spectrum. So how to identify a minimally competent candidate? Before making the judgment, the SMEs must agree on the definition of a minimally competent candidate. All judges must have the same standards of a minimally competent candidate for the NCOF cutoff score to be reliable. For this purpose, the SMEs are required to determine the characteristics of a minimally competent candidate and develop criteria by consensus for their identification, and there should be a formal discussion among them. Obviously, because they have to have a same understanding or similar picture, so they must get an opportunity to discuss and elaborate on this. The criteria for minimally competent graduate ensure that the standards are tied. Yeah, again, very important statement here. The standards are tied to the clinical safety and actual competence, making standard setting process legally and academically defensible. That's a very important statement in this context. The criteria of minimally competent candidate may differ in between two OSCE stations. Yes, of course, we have discussed that. It depends upon the nature and the level of the assessment. The identification of a minimally competent candidate should be based on the minimum acceptable level of knowledge, skill, and professional behavior expected for that particular stage of training. Obviously, if we are talking about first professional, our level would be different as compared to, for example, a final year professional. Again, as I said, depending upon if the station is, for example, on resuscitation of a newborn baby, our minimum acceptable level would be very high as compared to some other examination. A minimally competent graduate must be a safe doctor. That should always be kept in mind. Whatever we do, whatever we are thinking, whatever marks we are giving, that is the statement which must always be there, that the student whom we are passing as a minimal competent candidate must be a safe doctor. Therefore, the criteria will be closely related to the context. For example, I mentioned that already, that the criteria about resuscitation of newborn versus assessment of development of milestones, speaking about pediatrics, so that cannot be the same. Panelists may write independently the characteristics of the minimally competent group per skill component, and the panelist statements are then posted and the facilitator discusses with the panelist each statement. So everybody write their opinion and then they discuss, and the discussion is facilitated, and then they come to a conclusion. Arguments and disagreements are clarified and the group reaches a consensus as to what would be an appropriate list of characteristics of a minimally competent candidate per skill component. So that may be for example, we were talking about station, or the question would be different. This process is essential to facilitate further the estimates and the judgments of panelists and to support the defensibility of the process, right? The criteria for minimally competent candidate in exit examination may be described based on the knowledge, clinical skills, and professional behavior. Now, what I'm going to present now is that this is what I conducted, let's say informal study, or you can say a survey among the different WhatsApp groups, the WhatsApp groups related to medical education, trying to develop a criteria for a minimally competent candidate. So, and then I have summarized. So it's something which may not be there in the books or in printed literature, because I just completed during last few weeks. So when we are talking about a minimally competent candidate, and we said that we will describe the criteria based on the knowledge, clinical skills, and professional behavior. So first thing is overarching criteria. The first thing which we must keep in mind, as I mentioned earlier, a minimally competent graduate must be a safe doctor, one overarching criteria. And secondly, know his or her limitations and when to call for help, right? Because these two are really, really important approaches for the safety of the patients who are going to be seen by these graduates. So they must be safe and they must know their limitations and where they need to call for help. This is the overarching criteria. The criteria in knowledge: a minimally competent graduate must be able to recall essential facts. For example, common drug dosages or diagnostic criteria, are identifying, for example, the hypertension cutoff values. Apply facts to straightforward clinical scenarios, for example, choosing the correct empirical antibiotics for community-acquired pneumonia. Interpret basic data or lab or images to reach safe conclusion, for example, recognizing diabetic ketoacidosis from lab values, and avoid dangerous errors in prescribing or in diagnosis, right? So that was the overarching criteria, and this is the knowledge criteria for a minimally competent candidate. Then the clinical skills criteria: a minimally competent graduate must be able to stabilize critically ill patients while waiting for further help, take an appropriate history and perform the essential parts of physical examination, describe the differential diagnosis based on the history and physical signs of common diseases, and perform essential clinical procedures safely. So this is the clinical skill criteria. And then there is a professional behavior criteria that a minimally competent graduate must be able to communicate well with colleagues, patients, and others. Prioritize patient well-being above all and other activities, and practicing with empathy and ensuring patient feel valued and understood. Listen to patient concerns and explain diagnosis clearly without using complex medical jargon. Uphold strict ethical standards, respecting privacy and being transparent regarding treatment limitations and healthcare costs. Stay up to date with evidence-based practices and maintain positive, respectful relationship with other health care providers. And they demonstrate sense of responsibility and punctuality at all times. So this was the criteria which I have developed based on the feedback from the various WhatsApp groups in medical education, and after discussion with the colleagues. Here is an example of, so this is an example from my institution, where we have this, the criteria for excellent or good pass, borderline fail, and clear fail, and the history taking and all. And here you see that we have a criteria here. For example, in focused history taking, obtains the main element of the history, demonstrates basic questioning skills, and identifies key findings with occasional prompting. Now, if an institution has already identified these criteria, so that is a big help for SMEs, right? So then we can simply show this criteria to SMEs, and they have to follow it, right? So in this way, if we work at the institution, and that would be mainly job done by medical education unit, if they have developed this criteria, so it would help so much and ease the process of training of SMEs. So this may be one area where those who are interested in medical education may like to work. Right? Okay, any questions so far? I think we have covered quite a bit of it. And the two, as I said, most important areas, minimally competent candidate and the SMEs, because understanding of these two areas is very, very crucial for the proper implementation of standard setting process. Any questions, comments before we go to this activity? Right? Okay. Now, here is the activity is extracting criteria of a minimally competent candidate from criteria of a fully competent candidate. I'll give you the example. This is the PLO, means program learning outcome statements. Program here means MBBS, and the learning outcome statements. And this is a statement, one statement about knowledge and understanding, and this is for a competent candidate. Apply a systematic understanding of facts, ideas, and principles to be implemented in the medical sciences and related healthcare areas. Now, if this is the statement for a competent candidate, then how can we modify it to suit a minimally competent candidate? That is the activity. So can we modify this statement, which is for a competent, fully competent candidate, to suit it for minimally competent candidate? So what would you say that if this is for a competent candidate, what should be expected from a minimally competent candidate? Dr. Shazia, would you like to comment? Or Dr. Memuna? Professor
Sir, I'm
Memuna?
analyzing the question. Just give me a little time.
Right, okay. Yeah, Professor Jamshed, Dr. Aisha, just think that how can we modify this statement to suit a minimally competent candidate? Because we have this statement for a fully competent.
Sir, could we give a percentage of understanding or
Okay, that's
as shown by so many marks obtained in the OSCE?
okay. Now let's say apply a systematic understanding of facts, ideas, and principles to be implemented in the medical. So you think let's say here we assume that because this is for competent, we think this is 100%. So we reduce that. That's what you are saying. Is it?
Yes, sir. Yes, sir.
Right. Okay. Any other ideas? Okay. If you look at it, the key word here is systematic.
I think for minimally competent graduate, it would be that he should be able to apply the basic knowledge of facts, ideas, and principles.
Can you repeat that statement, please?
I think for a minimally competent graduate, it would be like this, that he should be able to apply the basic knowledge,
right,
and ideas that
right,
are common in the healthcare situations.
All right. Yes, I think that's a good one. Is basic.
I feel that, sir, I feel there are two keywords: systematic and implemented. So if
Right.
we reduce the apply a basic understanding of the facts and principles in the medical sciences and related, I mean, if they're not able to implement, then also an understanding, if it is not very systematic, I guess
Right.
these
Yeah.
are the two words I feel.
So okay. Yeah.
And
That's another idea. One is we use the word basic or
also,
essential.
yes, basic, and in the later part, there should be something like the common healthcare issues,
Right.
or common healthcare related problems
So we can say
that are more prevalent in the community.
right. Good. So we can say basic or essential facts and ideas. Second, for common diseases. Right. Yeah. That could be one modification. The idea of systematic understanding. Maybe it's not systematic. It's maybe I don't know what word can be used rather than systematic.
So if we look at the statement, there are two things in it. One
Sorry?
is there are two things that we have to look at this statement
Right.
for a minimally competent candidate.
Right.
One is the systematic understanding, which
Right.
is a competence in itself.
Right.
And the other is the content of the curriculum, which would be the facts, ideas, and principles.
Absolutely
So
right.
I think the systematic understanding is the basic competence that is required for every practicing doctor. So that
Right.
should be compromised when we are defining the minimally competent. They have to have a systematic application of their knowledge. But what we can look at where the compromise would come would be in the core and the non-core part of the curriculum.
Right. So if we combine these two, let's say like Dr. Aisha is saying that we must maintain the systematic understanding of common and our basic or essential, or essential facts and ideas and principles to be implemented for common conditions. Would that be something acceptable?
Okay.
Yes, that's acceptable, I think.
Yeah. So
Basic.
basic. So this is, let's say, one way. We have a statement for a fully competent candidate, and from that, we come up with a reasonable expectation that a candidate who is minimally competent must have that, right? So if you go to the previous example I showed you here, this is exactly what has been done. That there is a criteria for distinction student, criteria for good pass. Here, for example, it says obtains accurate, relevant, and comprehensive history independently. Then it says obtains accurate and relevant history. Then obtains the main elements of the history, right? So in this way, we can actually develop a table like this. And once we have it, it would be so useful to train our SMEs and apply this concept while implementing this standard setting process. So similarly, there can be a statement for practical skills. Demonstrate comprehensive basic practical skills to ensure safe practice in the medical and related health. Again, we can say the essential basic practical skills, right? Similarly, we can deduce from the communication skills, communicate effectively with the patients, their family. Usually the soft skills is remain the same. It's for that. So this is how we can actually come to a criteria that can be used to identify a minimally competent candidate. So means that whenever we are evaluating a question, whether it's a multiple choice questions or it's an OSCE, so we keep this criteria in mind before we saying that what percentage of minimally competent candidates would be able to answer that question correctly. Right. Okay, so now I think this part we have in a way done already as well, that the what percentage of minimally competent would answer this item correctly. That's the first question. Each expert's judgments for an item should be in the same or within a close. Now, if the difference of opinion between the two SMEs is less than 10%, then we can take the average. But if it is more than 10%, then we ask them to discuss again and come up with the consensus, right? And the mean of everyone's judgment is calculated for each difficulty, for each item, and this is often referred to as predicted difficulty, means the average of each item, and then we take the average of all these averages to come to the pass mark, which I have shown you earlier as well. And this is the first round. And if we find that there are some areas where the SMEs have a difference of opinion, then we can separate those items and we can have a second round and come up with this table. Right. So that is the NCOF method. Now we will go through the this method of borderline regression method. So it's not going to take long, and it's very, very straightforward to understand. And as I mentioned earlier, we are using for our OSCE stations. So borderline regression method is the in absolute examinee centered. Now ANCOF was test centered, or similarly the ABLE was test centered, but this is examinee centered, means that here we are looking at the performance of the candidates as opposed to the level of questions. Right? So borderline regression is an absolute examinee-centered standard setting method that is widely used to standard set OSCE exams. The actual marks that all candidates scored for a station is plotted on a graph against the global rating they were awarded for the station, and a best fit line is drawn. So important here is, you look at this example. As an examiner, I would take here, based on this, I will take on this. Maybe here, for example, is done satisfactorily, but here is poorly done, or here it's not done. So I would just take this, but I would not total it up. That's very important, because the totaling would be done later on by the exam division. But I would take one of these boxes here. And one of the reason of not totaling is that because if I total, then my global rating would be affected. So I give a marks, and then I also take whether overall as an examiner, my assessment is whether student is a clear fail, is a borderline pass, or a clear pass, or a good pass. So I have marks here, and I have my overall impression here. So this is global rating, and this is the marks. So for each candidate, let's say I'm doing an OSCE and there are 40 or 50 candidates who are coming this. So I'm marking all of them and giving the global rating. Then in this borderline regression method, candidates' performance on stations or cases is scored in two different, like I said just now, holistically by a global grade, and also with the checklist or domain-based, which I explained in the previous slide. The checklist score is regressed on the global grade, and the station level standard is set post hoc using the regression model predicted score. I'll show you the graph here. Right now, maybe this one would be the better example. Now here is the global rating. 1 is fail, 2 is borderline pass, 3 is clear pass, 4 is good pass, and 5th is excellent pass. So, and then once we have plotted this, so these are students' marks, right? And these are their the global rating, and then we draw a trend line. And okay. Now here, number 2 is borderline. So if I look at this, and this is the trend line, and if I go from this, so probably the pass marks becomes 53 for a minimal or a borderline candidate. So if I go to the previous slide again, you see here again, here they have different global rating, but whatever global rating is, for each global rating, they plot it in the graph. You can even plot in the PowerPoint, or you can use for example, Excel sheet or others. And then we draw the the trend line, and if you see here, it would be maybe, let's say 22 as this, right? So means there, in summary, is that we mark the students on the this mark sheet according to the checklist, as well as we give the global rating, and at the end we plot the marks against the global rating, and in that way we come up with the minimal competence or minimally marks required to pass the exam. They can do it in different ways as well, like the same example, but in line graph, which is borderline pass is 53. We can also do it for others as well, like clear pass would be the 60, the same example, right? So this would be the borderline regression for OSCE, and it would be different for each station, right? Because their assessment would be different for each station, right? Okay, any question on that borderline regression?
I have a question.
Yes.
You showed a rubric
Right.
For assessment.
Right.
How does that rubric fit in with the borderline regression method?
Okay. Now, this is what you are talking about, right?
No, this is not what I was talking about.
Right.
There was another one. I think it was even before this. अगर आपने कहा सक, if you can bring it.
This one.
नहीं.
This is Ankoff method.
No, maybe it's after this one. No, sir, I think I've.
All right.
It was
Okay.
in blue.
Here.
It was in blue.
After this
Blue
is this slide, and then is this one. And then is this one. Or probably you were talking about when I showed you the same, and I asked you, we highlighted the must areas.
Sir, probably just before the activity, the slide that you had shown,
maybe
your own
not.
institute.
It was large boxes and it was in blue.
Okay, let me see
जितनों
that.
की आप बता रही हैं.
सर मैं आपसे एक क्वेश्चन करना चाहती थी.
Actually, this one, are you talking about this one?
Yes, I'm talking about this one.
जी.
सर आपसे मैं एक क्वेश्चन करना चाह रही थी सर. जैसे हम यूनिवर्सिटी में फाइनल ईयर के पेपर चेक करने जाते हैं और एक ही क्वेश्चन को बहुत सारे टीचर्स जाके उसको देख रहे होते हैं, मार्क्स लगा रहे होते हैं, हालांकि वो मार्क्स बिल्कुल डिवाइडेड होते हैं 1 2 3 करके, लेकिन फिर भी थोड़ी बहुत डिफरेंस हो जाती है. सर ये जो आप बनाते हैं कि 10 जज हैं, ये उस सिचुएशन को कह रहे हैं जो हम यूएचएस वगैरह में जाकर करते हैं?
मैडम, ये जो है ये एग्जाम से पहले है.
सेंडअप्स में?
हाँ, नहीं सेंटअप में नहीं, ये आप जो क्वेश्चन आप बना रहे हैं उनको असेस कर रहे हैं. बेसिकली जो आप यूएचएस में जाके कर रहे हैं, आपने उसमें पास स्कोर पहले से डिसाइड किया हुआ है. आपने पहले से कहा हुआ है कि 50% पास होगा, जबकि स्टैंडर्ड सेटिंग जो है वो उस 50% को नहीं मानता. वो ये कहता है कि ये एग्जामिनर पहले आपस में बैठ, जिस तरह आप कह रहे हैं कि पांच एग्जामिनर फॉर एग्जांपल, आप मार्किंग से पहले आप ये देखें कि आप जो है पास मार्क आप 50% नहीं फॉलो करेंगे. आप आपस में डिस्कस करेंगे कि ये क्वेश्चन ऐसे हैं, इसमें पास मार्क 50% होना चाहिए या उससे कम होना चाहिए या उससे ज्यादा होना चाहिए.
सर आपका मतलब है कि जब पेपर मेक किया जाता है यूएचएस में जाकर, उसमें सारे एग्जामिनर बैठ के क्वेश्चन बनाते हैं और फिर उसमें मिलकर डिसाइड करते हैं मार्क्स?
एब्सोल्युटली राइट, एब्सोल्युटली राइट, एब्सोल्युटली राइट, कि वहां पे डिसाइड करें कि हमारे ये क्वेश्चंस का लेवल है तो इसमें पास मार्क क्या होना चाहिए. एब्सोल्युटली राइट.
थैंक यू सर, थैंक यू.
यस, दूसरा वो कौन सी रूब्रिक्स के हम.
Yes, sir. This is exactly the rubric that I was asking.
Yeah. So
इधर तो आपने लिखा हुआ है.
हाँ,
Usually जो हम sorry, अब आप
हाँ,
बोलें सर.
मैडम ये जो है ये आप ये असेस कर रहे हैं कि एक बॉर्डर लाइन कैंडिडेट से आप क्या एक्सपेक्ट करते हैं, राइट?
ठीक है।
और
अच्छा, this has been constructed
जी
by the subject experts.
हाँ, ये जो है सब्जेक्ट एक्सपर्ट्स इसको वो करेंगे, प्रिपेयर करेंगे,
Okay, ठीक है।
राइट? सो दैट वाज द borderline regression method. Any other question about this? ये ज्यादा मुश्किल नहीं है, ये ज्यादा मुश्किल नहीं है। इसमें सिंपली अगर जो एग्जामिनर्स हैं उनकी ट्रेनिंग कर दी जाए, और जो रूटीन में होती भी है कि ये एक चेकलिस्ट है, इस पे आप कैंडिडेट को मार्क करें, साथ ही अपनी जो है ओवरऑल असेसमेंट दें। अब जब उन्होंने ओवरऑल असेसमेंट देनी है, उसमें वो जो एसएमईज की ट्रेनिंग है वो इम्पोर्टेंट हो जाएगी कि सब के जो है शुड हैव अ सिमिलर आइडिया के बॉर्डर लाइन कैंडिडेट क्या होगा। तो इस तरह से अब आप देखें कि हर स्टेशन का एक अलग पास मार्क होगा जो पहले से डिसाइड नहीं होगा, बेस्ड ऑन
सर ये जो आपने पूरा बनाया हुआ है सर, ये हिस्ट्री टेकिंग स्टूडेंट की, जब वो पेशेंट की
हाँ
अस्थि की सूरत में हिस्ट्री टेकिंग होती है, इवन एग्जाम में एक एक उन्होंने हिस्ट्री टेकिंग का लिखा होता है, दूसरी साइड पे डायग्नोसिस और ट्रीटमेंट के दो स्टेप।
एब्सोल्युटली, हाँ बिल्कुल सही कह रही है मैडम, बिल्कुल। इसमें जो आपका जो ऑस्की स्टेशन है वो हिस्ट्री टेकिंग भी हो सकता है, फिजिकल एग्जामिनेशन भी हो सकता है। आप
सर वो जनरली जो अभी फाइनल में कर रहे हैं ना एग्जाम में,
जी
तो सर ये फर्स्ट में पेशेंट होता है वहां पर हिस्ट्री और एग्जामिनेशन होता है, और सेकंड में जाकर एग्जामिनर के पास डायग्नोसिस और ट्रीटमेंट
हाँ
होती है।
सही है। वो बल्कि हर स्टेशन पे जो जो हिस्ट्री टेकिंग स्टेशन है उस पे जो एग्जामिनर हैं वो अपने हिस्ट्री टेकिंग के हिसाब से मार्किंग करेंगे, और जो डायग्नोसिस पे जो एग्जामिनर हैं वो वहां जाके उस पे
सर
करेंगे।
ये जो आप पेज है ये एक्चुअली हिस्ट्री टेकिंग वाला है।
ये काउंसलिंग वाला है, ये काउंसलिंग वाला है,
अच्छा ठीक है।
राइट।
Sir, in response to one question that was asked by one of the participants, that what we do as examiners at UHS or any other medical university,
जी
I don't think any of us is doing standard setting. Even UHS is not doing standard setting. What
जी
we are doing there is developing a marking scheme for the individual questions, and
राइट।
the cutoff is already set at 50%.
हाँ
And we just decide, and we are not looking at the minimally competent candidate. We are looking at who would be able to secure 50% in this station, and that we consider as the borderline.
no, that is the problem, no, madam.
Yeah, that's the problem. That's
That's
the
the
issue.
problem. अब
So nobody is actually doing standard setting.
जिसमें इसका मतलब ये है कि आप हर सिचुएशन, जो मैं एग्जांपल दे रहा था कि एक रिससिटेशन का स्टेशन है, उसको भी आप 50% मार्क्स पे पास कर
इसी
रहे
तरह
हैं,
से है सर, इसी तरह
और
से।
एक जो है एक एब्डोमिनल एग्जामिनेशन है उसको भी उस पे कर रहे हैं। तो विच इज
Which is very dangerous.
या वेरी डेंजरस, पोटेंशियली वेरी डेंजरस।
I may, this 50% pass cutoff rate is so illogical. That means कि your graduate who's graduating even from the top university, you expect कि 50% of the time they would get the diagnosis wrong, and of those 50% of the time that they get the diagnosis right, they would be allowed to prescribe wrong treatment. So this is so illogical. I don't know where they came up with, but everybody is doing that.
No, absolutely. I think we need to. So the one,
It
hopefully,
is so
the
restricting, this
participants of this
50%
workshop,
thing.
they can go at least raise your voice in any faculty meeting या उसमें। और ये इस मेरी प्रेजेंटेशन में ये लग रहा है कि it's a very sort of what we say is tedious process, but actually it's not. To start with, yes, but once
Sir, I have a question as well.
yes,
We can, like all the medical colleges here, they're affiliated with certain universities. Like where I work, it's affiliated with NUMS University. So we
right,
have to follow the passing percentages our university have told us to.
right.
Still, we can do these standard settings in our class tests or block exams, but
Correct.
eventually we have to follow the standards that are given us to us by the universities. So this should be implemented at the institute level or not?
I think, madam, it would be actually easier. Let's say under UHS, there may be 30 medical schools. So rather than doing 30 medical schools, you do in one university, and that can go to all those medical schools, and there would be a uniform
Exactly.
level. And of course, as you said, you can do in your internal examinations or the posting or block examinations can also, you can start practicing from there.
Okay.
Right? Okay. Right now, let's go the last bit of this, and this is again very, very simple method of Needleski's method, and that's why this is light, because this is very, very simple. And again, it's the before the examination. Needleski's method, which is item centered, the subject matter experts make decisions on a question by question basis regarding which of the question distractors they feel minimally competent candidates would be able to eliminate as incorrect. Means what the SMEs do, they look at let's say the 4 or 5 statements, and first they think that, okay, which of these 4 or 5 statements a minimally competent candidate would delete in the sense that they would say, okay, they are absolutely confident that is a distractor, that is not the right statement. I'll show you the example. And then the minimal pass level for that item is computed as 1 over the number of options remaining. Means that if you have already eliminated 2 options, so only 2 are left. So the minimal pass level for that question would be 1 over 2, which is 0.5. I'll show you here. Let's say it's a 1 on a 5 option item. If a subject matter expert decides that the minimally competent examinee will recognize correctly 2 options as being incorrect, the minimal pass level for this item will be 0.33, that is 1 over 3, since 3 options remain after the 2 incorrect options were removed. So 5 options minus 2 distractors removed, remaining 3. So 1 over 3 is 0.33. Here at okay, I'll show you here, right? So this is question number 1, and there are the 4 options. And what the SMEs think that the statement A is so obviously wrong that a minimal competent candidate would straight away ignore that. So this means that then student has to choose one of the 3, B, C, and D. So if 1 over 3 would be 0.33. Whereas in this, let's say, second question, there are 2 statements with SMEs think that a borderline candidate can easily eliminate, then only 2 are left. So the student has to choose one of the 2, and that. So this means here what they are doing is that first they are eliminating the so-called obviously wrong statements, and then looking at what is the chance of correcting the right option from the remaining statements. So, and this is for each question, they would calculate this, and then they would be the cutoff score. So this seems so simple, so simple to practice.
Sir, may I ask something?
Yes, please.
Sir, during vetting of the MCQs, there also we tell them to eliminate any item which has too obvious distractor.
Right.
So some of the questions when they come here for standard setting, they might not have any obvious distractor. So is this a appropriate
Yeah,
method?
absolutely right. I mean, in vetting process, you make the question as perfect as possible, right? But out of those 4 statements, 3 are distractors, right?
Sir, yes, sir.
3 are distractors. Now, based on the training of SMEs, they have to think that a minimally competent candidate would be, if they think that the minimally competent candidate would not be able to remove any distraction, then it would be 1/4. That would be 0.25. Right? So that would be,
Okay.
but
Okay.
what they do is that they never say that none of them would be able to do it. So once we have vetted and we have perfect questions, then these SMEs are looking at it, and based on their idea that what a minimally competent candidate will do, that they would they neglect these 2 options, and they would think about these 2 options and choose one of them.
Understood. Thank you, sir.
Yeah. Okay. So this is an example that there are 15 items, and this is how what the after the no, these are, let's say, the 6 examiners, and this is their opinion, and then the item mean is calculated and the total mean is added, and that becomes the pass mark for a minimally competent candidate. So this seems really quite simple method of doing it. So it is because this is transparent, this is simple, and this is feasible. However, there are limitations that it can be used only for MCQs, right? And there is a subjectivity, that decision making about the probability of a correct answer by minimally competent candidates. So here is the point where the training of subject matter experts would count a lot. It assumes that the test takers answers MCQ by eliminating the options that they think are distractor, and then guessing randomly between the remaining options. So that is the basis of this thinking, that students would first eliminate the distractors and then try to guess which is the right answer from the remaining option. But however, the test takers may not follow that strategy. So not everybody would answer the questions in that way. So that may be the limitation of this method. Raters tend not to assign probabilities of 1 to judge that. So nobody would say 1 because otherwise they means that the minimally competent candidate could rule out all incorrect responses and options and take only 1. So usually because we think that is that ability is for high performing students. So a minimally competent candidate may not be able to do that. So if it is, for example, a 4 statement or 4 option question, so minimum they would give is 0.5. And in this way, a lower passing score is possible. So that is another limitation. So this method tends to produce lower cut scores than other methods, and therefore likely to increase the number of false positive or false pass. Right? So we have discussed quite in detail and actually had practice as well on different standard setting methods. We felt that this is a tedious process. This is a time-consuming process, and it is, but mainly for the first time. But there are other limitations as well. As I mentioned, that even with standard setting methods, we cannot be 100% sure that our decisions are absolute correct and perfect. There would be limitations. Always there would be limitations, as there is no single perfect method of assessment. So all standard setting methods involve expert judgmental decisions at some level. So that is a common feature in every standard setting method, and that makes it subjective, because the subject expert method decisions, we try to minimize it by the training and having more number of subject matter experts, so that we can reduce the subjectivity to minimum. All standard setting methods have to identify a minimally competent student, again a subjective nature. And again, the answer is same, that the extensive training of subject matter experts would help in reducing the subjectivity. Variability in standard setting results in different centers or at different times is possible. The most popular test-centered methods are the Enkoff method and Abel method and Nidelsky. And these methods have been criticized for two reasons. First, it is very difficult for standard setters to imagine the knowledge and skill level of minimally competent candidate in order to estimate the probability that they answer an item incorrectly. Obviously, this needs a little bit practice and discussion among the subject matter experts. And secondly, if standard setters are changed, the pass marks may also change, because this is subjective in nature. There are 30 or more standard setting methods have been grouped in relative and test-centered and student-centered. So, but today we mentioned 4 of them, and I think personally I feel I don't need to really learn all those 30 methods. For practical purposes, 2 or 3 methods are good enough. And the positive thing would be that we are using the same standard setting method continuously, so that at least some standard of our assessment is maintained. Otherwise, if we don't do this standard setting method, we would every time would be a very different outcome. A study was conducted in our medical school, and based on the OSCEs for preclinical years. And the study, which compared 5 common standard setting methods employed in medical education assessment, found that norm referenced and the borderline regression method have high cutoff scores. So when the cutoff scores are high, of course, the failure rate is high. And the other state was not really very encouraging. The study concluded that cutoff score and the failure rate differed with different standard setting methods, and the choice of method is contextual depending upon the availability of resources. So if we limit ourselves to these 3 or 4 standard methods and just use them continuously, probably that would be more important to have a consistent results in our assessments. I think that was the last slide in this session. With that, I thank you for your attention and for joining this workshop and contributing. And I would be really happy to answer if you have any questions. Right, any? Are there any questions or comments? So
Thank you so much. It was a very informative session. It was a very good revision. I've actually done my master's a couple of years back in medical education, but some
right.
of the concepts that you have explained, they were really, kind of like an eye opener. I just have one comment. If different standard setting methods cannot produce similar results, don't you think there is this concept of discrepancy, reliability is in question?
Absolutely right. Absolutely right. I fully agree with that. But unfortunately, without standard setting, it would be even worse. So with this, if we choose one or two standard setting methods and follow that, at least we have some consistency. But without them, I think we would be are going haywire. So at least, but I must say that, and I openly keep on saying that there is no single method or foolproof method. We have to choose the most appropriate among whatever is available. But I fully agree with your views.
Thank you, sir. Thank you once again.
Yeah. And any other comments or questions? Right. Thank you very much. I will maintain that WhatsApp group for some time. And if you have some afterthoughts or other questions, you can always pose in that WhatsApp group and we will try to answer that. Similarly, please keep the stay in that group till the certificates are issued so that everybody gets their certificate. And if there are any queries, we can post through that WhatsApp group. Thank you very much.
Thank you, sir.
Thank you.
Thank you very much.
Thanks.
Thank you, sir.
Thank you.